All right, so this is sort of, I don't think you've had a formal overview of our non-health system of where people get coverage. So much of today is going to be that. It's going to be sort of a broad overview of where people are getting covered and how they're getting covered under Medicare specifically. We'll touch a little bit on bankruptcy as well, because I don't know if we're going to be doing that later in the sessions. So 52% of Americans receive their care from employee-sponsored insurance. And we know the sources of the treatment is from the employer, the workers' out-of-pocket costs, their payroll tax, what comes out of their salary, and federal tax, not a payroll tax. I'm sorry, that was a misspeak. So more than 50% of Americans get their coverage through their workplace. Medicaid and the Children's Health Insurance Program covers almost 20%, 7 million children, 80 million folks living in a modest degree of poverty. Those are, of course, funded by state and federal taxes. You hear a lot about Medicare, but it really only covers another 20% or 19% or 65 million Americans. However, because the older folks have more medical needs, of course, its costs are substantially higher. The coverage for Medicare and Medicare Advantage comes from the same pools, by the way. Those are federal taxes, out-of-pocket premiums that go and other agencies that we'll talk about. The Affordable Care Act via the marketplace covers only 6% of Americans, or 21 million people, but that's 21 million people who are now not uninsured. And as discussed, that's also through federal taxes, which provide a lot of the subsidies for folks on Medicaid and the ACA. And out of pocket with also tax credits providing premium support for those who are not eligible for Medicaid. Private coverage, people getting their own indemnity insurances, their own forms of insurance. That's a small percentage, that's 2 million Americans, but those who could afford it. The VA system and TRICARE for life, covering folks who are military connected and their families. That's not trivial. That's 16 million Americans. Those are purely federal taxes. Uninsured accounts for 8.3% of the population. It's 23 million Americans. It's interesting, the ACA percentages did increase some, as did other phenomena during the pandemic. We maintained more people on Medicaid. The other thing to be aware is many seniors who are on Medicare also are eligible and get covered by Medicaid. So it's not just Medicare for many. This is a graph, pie graphs that just demonstrate we talked about in the history that led up to the ACA, something needed to be done because people were losing insurance via the employee-sponsored insurance pools. During recessions in 2009, employers stopped providing health insurance, particularly smaller companies, and more people entered the gig economy. So this is basically just demonstrating. Can you see my, you able to see my pointer here? Yeah. So as you see, in 2009, the number of Americans who are covered dropped from 50% to 47%. Again, with the Great Tsunami, more seniors are aging. This is a relentless a trend with the baby boomers that will level off since the last baby boomer was considered 1965. But that grew. Medicaid during this time grew with CHIP. This is now 7 million. That's not up to date, but I just so this gives you a sense of the coverage. Again, a very important take-home message when you read about statistics in the United States. The overall U.S. metrics and statistics do reflect the fact that insurance coverage is not uniform from state to state. And I think this is a good chart. This is from actually the US Census Bureau, which is where a lot of this data is obtained. That shows the dramatic difference. How do I get rid of this thing? between states. Massachusetts, but in 2021 and 2022, had about 2.4% folks who are uninsured. During those same years, 2021 and 2022, if the trend is the right direction for Texas, this is 2022, but 16.6% of their citizens had no insurance, even though they may have been working, even though they may have been whatever their status was. So that's important to recognize. And again, that has to do with expansion of the ACA, which we've talked about. I'm going to just throw some more charts at you because I think it's just good to have the overview. As to how much we spent on healthcare, 4.7 trillion were some of the estimates from 2023. Remember 2021, some of these dollars were suppressed by the pandemic and nobody going to the hospital to receive elective care. So those $4.25 billion, that's $2.2 trillion. Where did it go in 2021? 31% went to hospital care. Even though the amount of services being provided in hospitals is dropping. So here's an important take-home point also that I think to remember. Remember, a lot of hospitals are shifting their treatments to the outpatient realm because they can make more income that way. But despite that, the fact that fewer people are receiving some of the treatments in the hospital setting, the hospital's service costs have never been higher. Remember, that has a lot to do with Dr. Verhoff, and I think I touched on some of this with consolidation and pricing by hospitals. So physician services covered fairly close second. This is 20%, 15% between, this is outpatient physician services and all clinical services, intravenous, reclassed for osteoporosis or chemotherapeutics, or intravenous hydration, or a variety of other outpatient services. So home health, a little 3%. By the way, you will not see long-term care on here. Home health is as covered not out and out but by Medicare or the VA. Nursing care facilities is typically Medicaid. So Medicare does not cover long-term care. Medicaid, however, does. So you'll see some long-term services covered by Medicaid. Prescription drugs, we talk a lot about them because it really hurts the pocketbook for many seniors. Again, that's a smaller percentage, and which is going to get smaller, hopefully, with future reforms in the recent Inflation Reduction Act, if it comes to fruition. Here's what people pay out of their own pockets for their healthcare costs, 16%. Government administration. Now that is probably including what CMS pays for administering Medicare and Medicaid. This is a segment here of private insurance administration. They're calling it in the Centers for Medicare Services net cost of health insurance. That's a substantial amount. That's 6%. That includes, by the way, the net cost of a private insurer having a bank of utilization review nurses and a bank of other folks to basically limit medical loss. Public health services, probably a little higher during this year, and investment in new construction or services that are provided. By the way, please, sure. And don't hesitate if you have questions, don't put them in the chat, share them, please. Please interrupt, because I can't see you guys while I'm doing this, and I can't know when you're scratching your heads.
Doctor, I have a question.
4.2 trillion in 2021. This is just a breakdown in statistics of the same numbers we just talked about. And
Dr.
again,
Dolkart?
yes,
Yeah, I had a question,
please.
actually. When we break down that, when it says physician services and clinical services,
Yeah.
are we saying, well, like the physician services, is that exclusively pay to physicians? Or was that designed to encompass all clinicians? Like, I mean, nurses, techs, aides,
Yes.
all of those.
That's interesting. I think that the nurse, in-hospital nurse would be under hospital care because you're
Okay.
basically paying for the hospital services. So I think the nurse who's based in the hospital would be get paid that way. However, this is all physician, or that includes ARNPs and physician assistants. So all clinician, I would say that should be under clinician services. So, so how much the clinicians are being paid for consultations, for primary care, for a variety of different office services. Clinical services refers to outpatient procedures and services done. That could include a fine needle aspiration of a thyroid, for instance, or a colonoscopy or something of that sort if it was done in an outpatient setting and not the hot. Does that make sense?
It does. Thank you. I just wanted to know how much our future
Yeah, and
profession is
that
specifically responsible. If we're accountable for 20 or 15% of it exclusively, or if that's basically the cost of personnel health care of people are putting hands on the patient outside the hospital, and that seems to be
outside.
what it is.
I think that's right. I think that's right. Yeah. Yes, Irby.
So I was wondering the basically kind of the salaries of the CEO as well as the salaries
That's
government.
that's a terrific question. You know, it
I
hadn't
just I,
occurred to me. I think that would probably be under private, thank you, under private insurance administration. So that would be the person who's administering those services. But yeah, that's really interesting. It'd be lovely to compare those numbers, for instance, with, how much it would save, how many hearing aids you can get for how much CEOs are. So traditional Medicare, we're going to talk about this, doesn't cover various stuff like eyeglasses or long-term care or hearing aids. I think it would be a small fraction in the pie chart overall, but so would hearing aids. And maybe if we didn't have CEOs, it would cover every hearing aid for every American who's got hard of hearing. So I don't have those specific numbers, but that's a really interesting question, and I
yeah,
think it
seeing
would be a
those, I was also
powerful.
thinking like government officials, like I feel like a lot of these people in the government like have a lot of money, so it'd be interesting to see like where our taxes go and like how much go to like salaries and then how much goes into like Medicare or Medicaid. It would be interesting to see that.
Yes, I have a chart that'll actually look at dollars that go to medical care coming up, but you're asking sort of a different question. So in this, so how much salaries would cost for for the head of MedPAC or the Health and Human Services? I think that'd go under that 1.2% government administration. So that's a lot of other salaries too, of course. So, interesting questions. Thank you both. Other questions? So, all right, we'll push on with statistics. You guys are brave. All right. So this is the proportions of public versus private spending on the total picture. Again, just giving an overview. Medicare costs were 22% of total national healthcare spending, and Medicare was 18%. Again, even though Medicaid and CHIP cover more Americans than Medicare, of course, the costs are higher for seniors due to the inevitable aging process and disease that accompanies it. Medicare costs were, in terms of overall federal spending, which is a separate concept. How much does the federal government expend on various things? It was about 13%, and we're going to have a chart on that, or 3% of GDP. Medicaid and CHIP were about 10% of the federal budget, a little bit less. Veterans care, 2%, global health, 1%. Less than that in terms of public health needs, even during the pandemic. So here's a proportion of public versus private for Medicare. Is this 13%? Here's Medicaid. And these are the rest of the federal outlays. And there's the other things we talked about. And Social Security. So in terms of non-medical expenses, how does that compare to what else we're spending for military defense and for other issues? Social Security, which is not, even though it's Medicare is administered by the Social Security Agency, Social Security, of course, is a different thing where you get payments to allow you to not be destitute late in life. That accounts for 21% of outlays in 2023. Defense here, that's non-discretionary defense. These are mandated payments that the government cannot vary from year to year. This is a non-defense discretionary spending. So for Head Start or education or 1,000 other things you read about. Here's the interest on the debt, but here's Medicare and here's Medicaid and CHIP in terms of our health system compared to the rest. Is that helpful just for when you talk with folks about how, the government is going broke on things? It is not a trivial percentage. And as we start to talk about Medicare Advantage and doing the things we can to maintain good health care, but not wasting dollars is going to be important. Okay. The question that Serby was asking about how much of these dollars are actually going directly to actual care, not somebody's salary or administrative costs or salary to a nurse. Well, I think the salary for a nurse would be considered actual care, not that for the CEO. So private insurers are still paying the brunt of healthcare costs. The dark blue is 2019. Here's Medicare coming from your tax dollar. Here's coming out of the pocket for your medical care. Here's Medicaid for in total, and remember the total includes states as well as federal. Here's the federal dollars. This is state dollars essentially, and so I don't. All other is probably VA and an Indian Health Service and a variety of other things. Okay. I don't know if this year we're going to have a speaker specifically on the topic of uninsured. I'm not going to spend a lot of time on this. So we know what our tax dollars are going towards. We know what private insurance is going towards. Here's a picture of folks in the South being served by RAM, Rural Access Medicine, and sort of the traveling vans that provide what you don't have to leave the United States to go to a developing country. We could bring you third world medicine right here at home. And here's a great example of that, where folks are lining up, they've not had care, they don't have insurance. That's that 15% of people in Texas. And this is just, I find morally abhorrent that we allow this to be the case. As doctors, we see suffering among folks like this, and it's just hard to fathom how we allow it. It takes a lot of work to allow that to happen. So anyhow, this is a breakdown on the origins in the United States of why people become bankrupt. Can I minimize this? Anybody know how to minimize this bar? Anyhow, sorry. Oops. Most people, the majority of people in the United States, not anywhere else, but the majority of people in the United States who go bankrupt, they have to declare bankruptcy, sell their assets, refinance everything and be beholden to a plan to pay their certain debts off. That's because of medical care, either because they develop a medical condition that makes them lose work and lose salaries and then pay bills as a consequence. So this is work loss due to illness or medical bills alone. 1/4 of Americans are going bankrupt simply on the basis of the bills they're getting from a hospital for a catastrophic injury. This is again unique to the United States. Remember, there was an effort to have unemployment insurance, but how well is that working in the United States? This is bankruptcy through work loss only, through getting unemployed, and bankruptcy, 33%, not having anything to do with health. So the vast majority is health related. The other important take-home point about bankruptcy is private insurers, even to this date, are able to minimize medical loss. And some of these folks who become bankrupt, by the way, have Medicare. So Medicare, traditional Medicare, does not have a cap on how much a person has to spend out of pocket. And particularly if you cannot afford the supplemental insurance that'll cover 20% of outpatient services or drugs, or you don't have Medicare Part D, there's a lot of reasons why folks on Medicare go bankrupt. Those same issues portend to folks going bankrupt on private insurance. So the majority actually, and some of these folks also have skinny plans. Some of this data is older, when more people were basically on these plans. Yeah, this is from 2009. This is before the ACA. And a lot of these folks also had plans that didn't cover their anything, that were basically just premiums to a company somewhere that would not pay out catastrophic care. Again, uninsured, that's not a surprise to us. VA and military, again, a bit of a surprise. So these are not, and this is unique to the United States that we allow this to happen. Other countries find that prohibit such financing of medical care. Here's an example of what happens if you have cancer, and the financial consequences. So there's 17 million cancer survivors in the US. CDC analyzed data on patients, not Medicare patients, on juniors. And this is not that long ago. This is 2019. The average out-of-pocket spending was about $1,000 for cancer survivors compared with $622 for people without a cancer history. 25% had material hardship associated with having such costs, paying for the forms of chemotherapy that their insurance plan said, no, we don't cover that. Going to see a doctor that's out of network because that's the only doctor in the area that covers some rare form of neoplasm, hospital debt that wasn't covered by their insurance, etc. This is not without its mental health consequences. Folks who deal with cancer, at least 35% of people are dealing with psychological hardships, to worrying about medical bills. It's not the so and spending all day trying to figure out ways to pay for these bills. There's a movie I'm going to show you that may demonstrate some of this with some personal stories. Anyhow, you know, how many of you have seen fundraising, GoFundMe for medical stuff? Yeah, it is nuts. This is the wealthiest country on earth. You were talking about what CEOs make for a living. It's one thing. It's great to have things move along, with employment and material goods with a capitalist society. But having this kind of disparity, not based on who you are, but based on whether you get cancer or not, is pretty atrocious. So 34, we talked about the hardships, and again, the ways that people have to try to get coverage. Here's a telling, I think this is a compelling chart, and this is from also from recent census studies. This looks at the percentage of people who are uninsured by age group. Ain't going to be a surprise. The younger folks who have children's health insurance, Medicaid, there's about 5% of children who do not have health insurance. Somehow, seniors who have graduated to be eligible for Medicare, we have 1% of citizens who do not have health insurance. Here's everybody else. In America, it's okay if you're working and your insurance doesn't cover it, you could be on your own. So this is between 2021 and 2022. So we still have substantial percentage of Americans who are uninsured. And one of the reasons a lot of the legislation that PNHP supports uses Medicare as a model. In part because it existed since 1965, but in part because it really is an automatic universal insurance. When I went on to Medicare, it was very easy for me to be getting information. I was paying Social Security. I was locked into the system. I'm an American citizen. I put in these many years of salary. It's available to me. Not for anybody else. So health insurance to help people stay healthy needs to be automatic. You want to decrease hassles. So that's just a little bit of a rundown. It's sort of just touching the surface like a dragonfly may on your local pond. But let's talk a little bit further about traditional Medicare. Any questions or observations or issues about the uninsured? Again, we've talked about free health clinics, which is one response, not the world's greatest response to it. How many of you know folks who are uninsured? So 2, 3, 4. How many of you know what may have be if those folks have had financial hardships or health hardships that have befallen them as a consequence? Yeah, Mac, what was and Gabriella, do you guys want to share a little bit about what those experiences were? Can you do you yeah.
I mean, I'm thinking very broadly and generally being in local, trans support groups and things like
Uh-huh.
that. I know plenty of people who don't have insurance, people who are no longer in contact with their bio families. So even though they're under the age where they could have maybe stayed on somebody's insurance,
Mm.
they're not on anybody's insurance
Isn't that
anymore.
interesting? Yes.
Obviously, trans people and queer people experience discrimination in the workplace, which makes it kind of hard to get a job that's going to give you a little bit of insurance. Um,
Mm.
and I mean, you mentioned earlier, like the GoFundMe's, the amount of begging that I see from my own community to my own community on the
Mm.
internet is incredible.
Yeah.
And a lot of it is medical, almost all of it is medical.
Yep.
And it's not
Yep.
all just for big stuff like your big surgical endeavors. I mean, it's just like people get sick and they just need
Yep.
help, or people are already disabled and they need assistance. And
Yes.
yeah.
Yes. That's really interesting. And you bring up the fact that children often become estranged from parents who can't accept, their who they are, and they can't get insurance as a consequence. So there's one thing to, it's tough enough to be estranged. It's another thing to not have health insurance because I don't want to deal with those with my folks.
It adds
Uh,
all of these layers to it.
yeah. Yes. Yes.
Yeah.
Very interesting. Very interesting. Thank you. Yeah, Gabriella, did you have an observation? I mean, you're at the top of my screen, so I'm sorry for. I'll try to keep an eye on everybody.
And I can add real quick that
Yes, no, never mind.
it definitely I think a lot of people fall into the category of making maybe a little bit too much for Medicaid, but not really having it in their budget to pay premiums even for ACA plan.
Yeah,
So I can think of several people in that category, just even in my family, and and with that, you're gonna, as we talked about, delay regular screenings.
yeah,
I can think of cases like people needing dental care, not
yeah.
having that vision. So I think a lot of people fall in that area where they're making too much to receive the Medicaid insurance, but not really being financially possible for them to regularly spend money on their health insurance, and so they don't go without coverage.
Thank you. That's really and also really critical. The ACA ain't that cheap if you're not making that much in the way of income. There's no question about that. There's a lot of people left in the hole. The ACA has its problems. No question. And dental issues, which again, thank you for bringing that up. These are real health issues. I mean, people have abscesses. People can't get malnourished because they can't chew. They can't afford dentures because they never, I'll give you I took my lucky enough to be able to take my family to Costa Rica just for vacation. And the cab driver was driving us around, and I noticed he had braces. And I said, wow, that's pretty cool. Where'd you get the braces? Oh, it's provided by the government. We have American dentists who come down to help teach our own dentists, but it's part of healthcare, isn't it, where you are? And I'm thinking to myself, where I'm driving, if I happen to get, this was some years ago, if I happen to get in a cab, I've noticed cab drivers don't have teeth. Or they have, and folks, so many folks have such poor dental care in the United States. And a lot of free clinics sometimes will have a dental clinic affiliated with it, but it's all volunteer and it's all nuts. Thank you. And any other, sorry for the editorials on my part, but and any other thoughts on this or any interesting observations? Because whether you know it or not, you're going to be, these people in your life. You're certainly going to be seeing folks who are uninsured in your life throughout your career. And that's another sort of moral injury to us as providers. Yeah. Should we move on? Oh, Gabrielle, did you want to say something or? Yeah.
Gabrielle can't say anything. She can't get off mute right now.
Oh,
So she's been putting in chat.
wow. Oh, I see. Okay,
So,
boy, I didn't know technology would do that. Be a great excuse if I'm talking for 5 minutes and I forgot to unmute myself. Yeah. Oh, oh my gosh. Right. So that's ghosting one of the two parents because of a divorce or something like that. Oh my God. Um, that doesn't sound legal to me, but that's another matter. All right, so let's talk a little bit about thank you. So and we may have some more discussion on the uninsured in the United States and its impact on things. For those who are insured, who happen to have Medicare, that's a great thing. Oops. And again, with the great tsunami, as a society, we are going to be paying more for Medicare to an extent. But it's really interesting how some of the projections for how much more we're going to be expending on Medicare did not come to pass. And we'll take a look at some of those numbers, even with Medicare Advantage, which is putting some stress on the system in terms of needless dollars. So how do we fund Medicare? I think that is something that you guys should know. The revenues for the total process of funding Medicare, 36%, only 36% comes from payroll taxes, 43% comes from general revenue. And the reason for that is the Part B, which is outpatient services, is not from payroll taxes. Most other countries, most other nations on earth, when you do your research, you'll see that payroll taxes fund all of a national health coverage costs. Here, this is variable revenues from year to year from taxation. It's not dedicated revenues coming from payroll taxes. Hospitalization is dedicated dollars. 88% of it comes from payroll taxes. It's a fixed amount. So, and it's not discretionary, it's fixed. As taxation on Social Security benefits, there isn't premiums. Seniors don't pay a premium on a monthly basis to get hospitalization costs. Then remember, this was part of the crazy how sausages are made in Congress about how the Great Society passed Medicare legislation. We need to revamp a lot of stuff. That's clear. So in terms of Part B, premiums do pay for, maybe 30% of it. That is based on income. There is an increase in premiums if you make more or if you're very wealthy. And then you have Part D, which we've touched on, we'll touch on a lot more, where it comes from general revenue. from that year's tax revenues generally. 14% comes from premium, and there is some contribution from other sources as well. Again, so that's where the money comes from. Where is the spending going to? So this is parts A and B, not in Medicare Advantage. You double this. So Medicare Advantage now, actually more than double, is 51%. We're going to have separate talks on that. But just traditional Medicare, Part A and Part B spending is $436 billion. Again, the majority being hospital services, physicians' fees, outpatient services, a very modest amount going to skilled nursing facilities that are doing rehab and essentially post-hospitalization care, home health services, visiting nurses, and everything else. So if you look at, sorry folks, spending by Medicare, you'll see that this is a chart that talks, just another way to represent inpatient costs for hospitalizations went up dramatically during the past 30 years. However, they've settled down. They're stable, and my guess is with future reforms, they'll start to go down. But so Part A, oh, I didn't mention Part A also covers dialysis and hospice care. So the projections are for Part B to be climbing because hospitals, which are getting pushback and limiting their revenue from inpatient services, are pushing more to outpatient services. So the projection is that actually Part B costs are going to go up with time. My bar here is obscuring this. Must be a way to minimize this bar. Does anybody know how to get rid of this bar? Hide floating meeting. There we are. All right. So here at the bottom here, this is Medicare Part D. There is a projection with the Inflation Reduction Act that those costs will go down, hopefully more than that. Again, Medicare Advantage is not separately financed. This is the total lump for both traditional Medicare and Medicare Advantage. Okay, so that's just another graphic way of, as to projections of spending, it's kind of interesting. And it varies from year to year. It's a political message about, the deficit, and we are spending a lot of interest on deficit. But as to how important that is depends on what you're trying to eliminate, it seems to me. So the predictions in 2009 about how much percentage of GDP Medicare would expend in let's say 2036, are far below what most recent projections include. And that is not because of Medicare Advantage, which is costing us more. There's uncertainty as to why some of these projections are less. Not all of it had to do with the pandemic, which decreased costs for healthcare in general in terms of expenditures. Here's just another graphic example. There's a Medicare insurance trust fund, basically, what people keep predicting is going to go out of exceed its revenue. This was the projection for when we'd be depleting it. That's been moved out, not because of increased tax revenues, but because of expenses. So any questions that I might be able to answer on that? Should I move on, or? Yes.
Yes, I definitely have a question on
Yeah.
that last slide. And I don't know if you want to speak about it more now, if we're going to talk about it more later at some point.
Yeah.
But the previous slide that you were just on about like projected
Yes.
date of depletion, because I
Yes.
have heard that basically the current trajectory of the Medicare program as it is, like, is not sustainable, and will soon deplete, and basically future generations, including our generation and after, is going to have to basically figure out what to do with it. And so based on these projections, and I see that you're making the point that no one really knows, and the projections have changed on a year-to-year basis. But what do you kind of make of those numbers, and where do we go from there?
I think it's a really important point, and I guess what you're bringing home is how much, well, how much politics plays a role, and how much the Heritage Foundation plays a role, and all these organizations that are put. So let me make it very clear. Remember, Part B was based on general revenue, right? And Part B is what's growing the fastest. Is projected to grow faster than hospitalizations at this point. General rev, look at how we're getting, so you don't need very big increases in taxation to make a huge difference as to how you're covering Part B. Does that make sense? There's so much discussion about the ultra wealthy paying less percentage-wise than secretaries and folks who are blue collar workers. We have a society that's fixed in its disparity. 2016, 2017, there was one promise that Trump followed through on. A major accomplishment was the cutting of taxes for the ultra wealthy and corporations. So all of a sudden it dropped from like 28% to 21% for how corporations, large corporations, were being taxed. So, and this is a reality for any health system. I don't care what system it is. If you hit a recession, you're going to have to be making some tougher choices. But this has nothing to do with recession. This has to do with the fact that we have such a non-progressive, a regressive taxation system. So it's this chart, you can draw that line and totally keep us solvent, just like by increasing taxation by 3% for folks, who make more than $10 million, who have with wealth or by income. Does that make sense? So that's number one. A lot of what you're hearing about how we're going to exceed the revenue that comes in the Medicare are folks who are pushing an agenda to limit taxes and to have trickle down economics. That, if you support the ones at the top, will float all boats, by by maintaining the income of the wealthy. And a lot of people forget during the 1950s, taxation rate was 90% of the wealthy. I mean, that's extraordinary to think about. But that's how, so there's the revenue side of this. I think that we've seen already, I've shown you some slides, and you're going to be seeing more. Dr. Malik will present some stuff on cost. The prices we pay for things in the United States are extraordinary. It's not we're doing more of them, remember? Every other country every country needs to have its projections and make sure they meet their budgets. But we're not, these projected numbers are not related to our doing excessive MRIs. They're partly related to the fact that the MRI costs 3 times that it is anywhere else on Earth. Okay? But it's really more, there are other factors at play here. Does that make sense?
Yeah. So so simply put, you're saying it would be as easy as raising taxes on corporations, and that would build the base of the revenue outside of payroll taxes, and just limiting and maybe regulating more the prices for the procedures and for the medical expenditure.
I think there's my take-home message around cost of healthcare in the United States, when we look at that, how far we are as outliers above any other nation per capita. Remember, we spend twice as much per capita, per person, as any other industrial nation on Earth. In my mind, 2 things: waste. So what's going into a health system where you're sending monies to CEO salaries, among other things, but also not just for profit of those companies, which no other country allows, but also you have these huge administrative wastes geared towards profit. By that I mean you've got the insurance companies with their utilization review boards and all the stuff that they're doing. But you also have the hospitals and the doctor's offices interacting with those various formularies, those various policies, those various covering problems. Remember, so waste is one, price is the other. That's one of the reasons I like UE Reinhardt's approach to it's the price stupid. What we're paying for and again, it's all related to profit. That's okay. People should invent new things. There should be reward for innovations when it's actually coming from a company. But those two factors are playing a major role for why we're such outliers. Does that make sense?
That makes sense. Yes.
And you really don't need to raise, again, this is a political matter. You don't need to raise, we have so much wealth. The 1% now has so much more than the 99% in terms of wealth. Looking at it as a society, how to provide some revenue from folks who can easily afford this is also not difficult to do. It requires the political will. So anyhow.
Right.
Um,
Thank you.
Dr.
Well,
Dolkart, I also
yes.
had a question on this slide. You
Yes,
mentioned that Part B was kind of the fastest growing
currently, yeah.
expense. Do you think there will be more of a push to raise the general revenue through taxes or to increase premiums?
Well, thank you for it. Actually, one other thing occurred to me. I have a slide on this. There's something called site neutral. There's also cutting back on how much you're reimbursing. I mean, hospitals are always, everybody's trying to game the system. So before we get to your question about revenue, part of the trend towards Part B going up in price is because hospitals get paid more to provide the same service in that setting and get paid more than in a doctor's office. So you've got these outpatient services connected with a hospital that are providing chemotherapy that are getting paid, twice as much for the same procedure and the same drug. So I think that there can be reform in how we provide reimbursement, by the way. That's one thing.
Can I just ask, so clarifying question on that front. So if it's an outpatient service that's provided by a facility that's affiliated with the hospital, is that covered by Part A?
No, no, that's Part B. It's interesting. So that's actually Part B. So it's dialysis, skilled nursing facilities, inpatient hospitalization. That's Part A. There's this carve out. Thank you. Really good question. Part B, remember those two wedges looking at clinical services and physician reimbursement? That falls under clinical services. So the hospital, it's the health system getting reimbursed under Part B. It's also oftentimes what puts people in the hole financially, or what the services they're paying for that they're going bankrupt under. So all good questions. You had a question about revenue that I forgot now. Sorry.
No worries. The question was do you think a way to continue funding Medicare if there's more of a push to increase general revenue or to increase premiums?
Oh, well, so maybe both. I mean, the premiums are capped when you get to a certain income. The whole intent of things like Social Security, here's it. I don't know what time it is. I do want to get too far behind, but really interesting political question. One of the reasons Social Security was accepted is, even though it's based on income, everybody gets it. So even if you're a billionaire, of which there are many now, and now there's 1 trillionaire, Musk will get Social Security. He doesn't need it, but by law, it's felt so everybody should get this. Same thing for Medicare, because it's open to everybody. It's means adjusted. But so you can say, well, folks who are getting Medicare maybe, and are really, it's a trivial income issue for them. Maybe we should raise the premiums on that side of things. Okay. They obviously don't need to use Medicare for insurance purposes. General revenue, yeah. I do think that general revenue, and often which is also vulnerable to discretionary changes, that does need to be raised. Clearly, we want to decrease expenditures as best we can. We want to keep an eye on the till, but there ain't enough coming in given the wealth that we have distributed in the country. So yes, general revenue should be bumped up. I don't know if we'll ever be able to. It's interesting, and when we talk about recommended reforms of PNHP supports, when we talk about Medicare for all, a lot of these issues do start to disappear because we're now talking about a universal national health service program and provision where the reimbursement mechanisms will change as well, if that makes sense. But yes, we need to bump up revenue to push that line out even further. But there's no emergencies, is what I'm saying. Even though we're having a lot of waste by Medicare Advantage, which we'll hear about further, we're doing okay in terms of the fund being depleted for now. So good. Just in terms of who is getting Medicare, again, do you guys know why there's more women than men here? Obvious. Women live longer, right? So you have more women in their 90s than you have men, just due to longevity. And in terms of ethnicity, again, this should represent the society as a whole. You don't have non-documented. The undocumented would not be typically receiving Medicare, but otherwise it would, again, it's a universal health insurance. Age, just for a breakdown, the majority of folks on Medicare paying those premiums have less health needs than those who are 85 or older. Those under 65 are folks on dialysis or folks with disability, by the way. That's not a trivial percentage. In terms of their health status, again, not surprisingly, at least a third of seniors on Medicare will have 4 or more chronic medical conditions. That can mean hypertension and well-controlled diabetes or minor COPD, but more often it means dementia, or it means malignancy or other issues. Functional impairment, which is a major predictor of both health outcomes as well as costs. So, by the way, this is a bit of a, do you guys know that functional impairment is often one of the major determinants of how somebody does after surgery? So you can be looking at, their blood pressures and their diabetes and their anemia and a variety of other factors. But if the person has a slow walking speed, or if they have dementia, that's going to determine their outcome after surgery more than most other things, by the way. It's a very strong general biomarker of the health of the person. So functional impairment is important. At least 20%, 1 out of 5 people rate their own health as fair or poor. And again, since up to 50% of people over the age of 85 have dementia, that number actually surprises me. That's a little larger than I would have guessed. I'd have to do the statistics. But that's obviously, that's where a lot of costs are being incurred, not by Medicare, but by families. Folks who have dementia, it's their families who are taking care of them, and they're not getting much reimbursement to do so. There's no long-term care that's part of Medicare. We've talked about supplemental insurance, MediGap, and essentially, most people have either MediGap or some other way that they have that 20% of Part B not covered. So half of people now on Medicare are on Medicare Advantage. For those on traditional Medicare, which is 30 million people, about a third of them have Medigap. About less than a third are still having Medigap covered by their employer or a pension fund that provides that. Medicaid, remember we talked about supplemental insurances being dual insurances. But you have 3.2 million Americans who do not have other coverage. And that represents a lot of the folks who have financial struggles. So Medicare as it stands, probably statistically better than for younger folks in terms of financial hardship, but there's lots of seniors who still are struggling with their health costs despite having Medicare. So this is kind of interesting. This says that half, this is from KFF, Kaiser Family Foundation. Half of people who have incomes less than $36,000 have financial strapping. Sorry. Of folks who have income of less than $36,000, a sizable, the next slide will show what percentage of those folks are having hardships as a consequence. And so I think my slides are goofed up here a little bit. Sorry. Some of these are just in. Again, this is looking at incomes, age, and sex. That's not what I wanted to get to. Sorry. But this slide you've seen before. Even those who are somewhat struggling, their outcomes are good. So in terms of having an automatic universal insurance, it makes a difference between how long people live and how their quality of care is. So we rank, you've seen this slide before, you may see it again. If you compare ranking of mortality as well as mortality related to amenable conditions, we do poorly. Yeah, we start to cover kids, so we do a little bit better, but we're ranked worst, bottom, sorry, when it comes to juniors. Lo and behold, you turn 65, all of a sudden, our longevity statistics for starting at age 65, by the way, and our mortality related to amenable conditions starts to climb dramatically, such that we're ranked near the top for those who have Medicare, which is really bizarre, but I think it's telling. What else do we have here? Use of selected Medicare covered services. We've talked a little bit about this. I'm going to skip that. This is talking about, remember we're talking about how hospitals shift services to get more revenue to a higher cost setting. There is legislation now that probably will be passed such that if you're doing the same service in the doctor's office versus in the hospital outpatient clinic, you'll get reimbursed the same amount. By the way, we've talked a little bit about how Medicare sets reimbursement in terms of relative value committee. And again, there's over 10,000 specific services that are fixed for a particular geographic region in terms of the amount of reimbursement paid for that. One of the reasons, and this is fee for service, this is an important concept. One of the reasons administrative costs in Medicare are so low, it's no more than 3% to administer Medicare compared to 18% for Medicare Advantage, is you're not grappling with deciding about prior authorization for every procedure. It's either covered or it's not. It's already legislated. It's covered or it's not. CMS has made that decision. Does that make sense? So when I have a patient who needs to have an MRI of their brain and I want to diagnose them for, I can, I'll see patients who have new onset or I'm diagnosing why they have dementia. I can make a decision between doing a CT scan or doing an MRI. If this patient was on Medicare Advantage or they were a junior, if they were 64 and I have to make this decision, I might get pushback from the insurance company. No, MRIs are too expensive. You need to order the CT first. You need to tell me why I'm getting an MRI. I'd tell you I want to look at the hippocampi in a coronal section or whatever. I could see microvascular disease a hell of a lot better, or whatever it might be, or see, amyloid angiopathy, whatever it might be. But the insurance company will give me hassles around that. Medicare will not. Because it's fixed. They cover MRIs for the diagnosis of dementia. And that's one of the things we encounter as clinicians in dealing with this. Now, you can have value-based reimbursement that's done in a sane fashion rather than geared towards profit, but that's another matter. that I know Dr. Malik, who may be on this, is very interested in discussing with you. Again, each system gets various specific funding. Skilled nursing facilities get funded based on a variety of factors, which is, how much nursing a patient needs, whether they're getting physical or occupational therapy, et cetera. But none of this covers the fact that folks are struggling to provide care for their loved ones in their homes. I'm not going to discuss ACOs, but I will say in terms of what our current, and I don't know if we're going to be meeting with, did you guys meet with the CMMI director yet? I don't think so. I think that may be coming up. So CMS has the Centers for Medicare Innovation, and they look at a lot of stuff. One of the things they have been pushing over recent decades is linking a mechanism of decreasing unnecessary costs to the organizational level. How many of you know what an ACO is? Anybody know what an accountable care organization is? It does not surprise me. Most of the public has no idea what an accountable care organization. A vast percentage of Medicare patients who are on these programs aren't aware that they're in an accountable care organization. So there's a fellow by the name of Elliot Fisher, who is actually at Dartmouth, who was looking at the uproar by the public against health maintenance organizations, managed care organizations in the 1990s. And he said, oh, let's change that. Instead of the insurance company ratcheting down on care by their prior authorization, let's have the health system, the hospital and doctors groups, the multi-specialty practices, let's have them look on their level about what is valuable and what is not to an extent. We'll reimburse that ACO. That ACO is basically a multi-specialty practice. It's basically a doctor's practice. That's all it is. It's a health organization. Remember, we talked about provider PPOs and physician hospital organizations, PHOs, et cetera, HMOs, health maintenance. ACO is just one more physician group, type of physician group. So this shared ACO programs contracts capitated wise, not through an insurer, but directly with Medicare. So, and I know this is health policy, folks, and it's Monday morning. Sorry about this. A lot of alphabet soup here. But so an ACO is a health system, is a multi-specialty practice that makes a contract with Medicare. There's no intermediary, okay? And that contract might have a carrot. We'll provide you more per member per month. We're going to pay you more for your services if you get everybody their flu vaccine, or if everybody gets a pneumovax vaccine, or if you have behavioral health built into your system, or if everybody's hypertension is, if you have a certain percentage of people whose hypertension is controlled. Does that make sense? So that's a positive. That's a plus side. The problem is there's also lots of sticks in addition to the carrots. So if you exceed more in your health dollars towards your care as in taking care of these patients, then we might, you're going to be at risk for paying for that. So we're going to get you a set rate. But if you spend more than that, you're responsible for that. Does that make sense? So essentially they're getting budgeted as to how much, but so that they have patients who need a heart, bone marrow transplants or a heart transplant, or they have some unique medical needs among their population, they're vulnerable for it. So for whatever reason, ACOs were felt to be a mechanism to limit Medicare costs. In reality, they haven't done so. I think we'll have speakers specifically around this matter, but I just wanted to give you an example of some of the trends happening in our financialized world that have taken off from CMMI. And this just shows the number of these ACOs operating in every state. There are other models for reform, and this is all under traditional Medicare. These are not concepts that PNHP necessarily shares or are built in necessarily to the Jayapal and Bernie Sanders bills in Congress, except I would say that the idea of global budgeting, I may have mentioned to hospitals based on their previously year's expenditure, is something that's being disseminated perhaps through the Maryland total cost of care model through CMMI. There are other models, independence at home demonstration models and rural community hospital demonstration models. Pennsylvania also has a global budgeting all-payer system for rural hospitals in Pennsylvania. Vermont's all-payer ACO model, I don't think Vermont is a fan of. I don't think that Dr. Malik is a fan of. I live in New Hampshire. I'm across the river. We live in a redder state than the efforts that Vermont has been making in its constraints. So, anyhow, this is just a slide on. Oh, I'm doing okay, I guess. On healthcare expenditure. I'm sorry, how people view healthcare. How are Americans feeling about the health system? For the first time since polling has been done, a majority of Americans now feel that the quality of healthcare in the US is only fair or poor. This is going back 50 years. For those middle-aged or younger, satisfaction has been consistently dropping since 2012. And paying for healthcare and medication is the top financial worry for many Americans. And again, boy, housing is I think housing is probably caught up by now. But housing, food, or retirement, at least when this survey was done a year ago, actually was less of a concern, which is pretty bizarre. So this is a share of U.S. working age adults reporting difficulty in affording healthcare. And as you see, it's not a trivial percentage. This is a survey of more than 6,000 Americans between ages 19 and 64. That's interesting. It may be because I was going to say this statistic seems high to me. I would put it probably about 20% of Medicare patients, but this is looking at juniors who are on Medicare because of disability. The majority of these folks have disability. Some of them have dialysis perhaps, but of folks who are on Medicare less than age 65, it's usually because they have medical problems. Half of them find that they have difficulty in affording healthcare. So again, there's some work to be done. And this is also in terms of the bringing it home to the personal level, almost 30% of adults in 2022 deferred or never received healthcare due to costs. 43% reported that they or their household family members put off care due to costs. 50% of low-income adults versus a quarter of higher-income adults deferred care due to costs. And this is just a graphic. Within the last 12 months, have you had to put off getting treatment because of the cost of care? What you see here on this graphic is over time that has not gotten better. And remember, more people are covered by the ACA during the 2000 teens. So a lot of those folks are actually already covered by some kind of insurance, but they're still struggling. Of course, the uninsured are the ones who tend to get the least care. And of interest, a high-income person, someone who's well off in the US, is still more likely to report financial barriers to getting their health care than low-income people in all other industrialized countries, or most other industrialized countries. And that's pretty reflective of the world we live in. So these unmanageable prices really do affect all of us. And I think that's just about it. This is just a slide I threw together that's not that relevant. I think, again, a few things to take home as points. Again, practicing medicine has been really rewarding. It's delightful to be able to help people with their medical issues. But despite overall increase in longevity and quality of life, we are now failing. Those numbers are now declining in the United States, largely due to lack of coordination to maintain health with primary care, disparities based on zip code and politics in a particular state, and our approach towards maintaining health. We are specialist driven rather than primary care driven. And in this day and age, financialized. We are driven towards profit in all of the health industry. Our costs are not related to providing more services, but it's due to waste and prices, and which have climbed out of proportion to other services. The medical industry is increasingly corporatized and geared towards profit. Again, despite the increased expansion by the ACA, we still don't have universal health insurance. It's increasingly unaffordable, and Americans are increasingly unhappy with it. So we're here for a reason. Any questions or concerns about the stuff that we've been chatting about? Thoughts? Okay. A little bit of
Can I ask a quick question?
Yes, of course.
Are these slideshows, PowerPoints, are they available anywhere? Because so many of the slides have so much information, like there's no way you could spend a whole time on it. And then two, I was going to ask is, what are the rules with regards to copying, for example, a PowerPoint while giving credit to, to who was the originator of it?
Sure. That's great. So number one, it's my fault that I haven't uploaded onto a particular site because we're recording these things. Those have been uploaded, but you have to watch the whole recording. I already have my primary care. I think you have a section available to you on where the slides are uploaded to. Are you aware of those? I'll make sure Betty gets that out to you for that site. I'll just confirm it. I've got them on a variety of sites on the PNHP, Northern New England PNHP. We'll make sure that they get all uploaded to one site that you can have access to. Okay. Some of them are up there, but I will share with you the links to them. Okay. So that's an important issue. So you don't have to go through the whole talk to look at the slides. There's a lot of statistics on here, and that would be valuable. That would be worthwhile. As to swiping charts, I have no problem doing that when it comes to large organizations that are funded for this purpose. And they know that we're doing this. In fact, I'm in communication with some of these folks. So like Kaiser Family Foundation, Commonwealth Fund. You will see a lot of our slides swiped directly from them. And in doing so, sometimes they have PowerPoint downloads. So they'll provide the slides. Not always. That's not an issue. When it comes to the original research, and this is, you don't necessarily need to be in touch with the person who's published the graph, as long as you give credit for the person who published the graph. So I usually try to have on all of my material, whether it be CMS, whether it be Census Bureau, whether it be KFF or Commonwealth, somewhere on the graph, and particularly when it comes to individual studies. Now, by the way, for instance, that graph on longevity and outcomes on Medicare, that didn't come from KFF. Oh, actually, that's on Commonwealth. That didn't come from Commonwealth. They quoted the original source. I went back to that original source to take the graph from there, just because for my education and better knowledge of this. So a lot of stuff is being disseminated. It's an interesting question. When you do presentations on scientific topics, you always want to give credit to someone who's done the research. Same in the world of health policy. You want to give credit, but you don't necessarily have to be in touch with every researcher that you shouldn't be to show their material. That makes sense?
Yes, it does. Thank you.
I will say what's really interesting, and I was on Google, you know, you do Google charts. I'm trying to find a chart on a particular topic. I finally found the chart I was looking for because I want to do more research about where its stuff came from. I clicked on it, even though it was actually supposed to go back to Kaiser Family Foundation. It went to Quora, which is this, you know, sort of research that the layperson does, and you got all sorts of, you know, crazy people on there with conspiracy theories and whatever it might be. I clicked on this thing, and it kept taking me to Quora. It couldn't take me back to and I let KFF know about that, because what may be actually attached to that slide may not be actually what was intended to be attached to that slide. That's the first time I've seen that. That's a little worrisome. And in the world of AI, you know, maybe there's going to be other concerns that you guys will have around this. But anyhow, so buyer beware. What time are we supposed to go to?
10:30.
10:30. I only had an hour for this morning on traditional Medicare. I'm sorry. But I think Dr. Malik is going to be meeting with you. Was it 10:30? He's going to join you. Anybody have this?
10:50.
10:50.
10:50. Okay. I'm wondering, I'm gonna be back. I'm gonna take a bio break. You guys should take a break. Why don't we just reconvene in like 5 minutes? We'll just decide what we want to do. All right? Oh, you could record it or not. I'll just let everybody get back on because I sort of were doing things on the fly. So, one of the things that just came out, this is hot off the press as of this morning. In the world that we live in, politics intrudes a lot on what we're doing, obviously, as physicians. How many of you have heard of the U.S. Preventive Task Force? So this is an organization that is not political, that I just want to make this thing smaller. I'm sorry. Keep struggling with my computer. But anyhow, it's a non-political consortium of researchers, academicians who devote their lifetime to looking at what is the impact of doing a colonoscopy on colon cancer. What's the impact of doing mammography? There's always controversy. What's the impact on whatever the study might be? And screening for dementia, screening for depression. A lot of the things that you do as clinicians and I do as a clinician is a direct consequence of what this group has determined through its research. And it's not always straightforward. The U.S. Preventive Task Force makes recommendations. It doesn't have binding recommendations to Medicare or other federal covered insurance programs like the ACA, but it usually follows its recommendations. There was, when the ACA was expanded, Accountable Care, Affordable Care Act was put into place, it mandated that preventative services be provided by all insurers. And these specific preventative services change with each passing year and get expanded or eliminated based on the recommendations of the U.S. Preventive Task Force. There was two Christian-owned companies that, and this is directly out of, I happened to find Axios. I saw this on some other news source talking about swiping things. Maybe we shouldn't be recording this or Axios may go after me. But this is like verbatim, but I usually don't do that. But the reporting is all uniform. The Affordable Care Act and the federal government was sued to say we should not be required to do the things that are being required by the U.S. Preventive Task Force. In this case, for religious purposes, they were objecting to the fact that there's something called PrEP for HIV. So it's basically medication you take, if you're having relations and you're at risk for having HIV. So these organizations said this is against our religious beliefs. We don't want to have to pay for PrEP for folks who are that we cover under our particular companies. This is a Texas-based Fifth Circuit Court of Appeals. They said, you're right, you don't have to pay for that. You can get a carve-out on that. The good news is they also said that, yes, the federal government can continue to use preventive services as part of the ACA. Now, this is probably going to, if I were the government, I would appeal this to the Supreme Court. Or maybe not, actually. Never mind. These days, maybe I wouldn't do that. But essentially, there was a previous court ruling that said all of the U.S. Preventive Task Force recommendations were invalid because it wasn't appointed by Congress. Now, by the way, there's a lot of things not appointed by Congress. Relative Value Units Committee that sets salaries for physicians, that's not appointed by Congress either. Somehow medical decision-making and medical stuff seems to be falling in the age of Tony Fauci, seems to have more political resonance than other things. So anyhow, this court outlawed using the U.S. Preventive Task Force. Today's ruling said, no, it's okay. The ACA can follow the recommendations of the U.S. Preventive Task Force. However, it agreed with the lower court that task force members need to be nominated by the president and confirmed by the Senate, which is kind of interesting. Well, maybe that's how it should be done constitutionally, maybe not. The bottom line is I always worry when you have an independent task force. Most nations on earth keep politics out of the task forces that make decisions about which drugs they're going to negotiate over what medical procedures. Here, you're now politicizing what is looking at medical care rather than trying to keep it as objective as possible. So I thought this is relevant when it comes to discussion of any healthcare system.